So I'll hand over to Dr. Rasik Shah, who is going to moderate and conduct the proceedings, the panel discussion on Empyema Thoracis. Dr. Rasik.
Thank you, sir. Good morning to everyone. I think most of you know me, so I don't need to be introduced as such, but we have galaxy of people or consultants who are going to discuss Empyema Thoracis. It should be more interactive, next one and a half hour, where panelists will answer some of the questions. You may ask some questions, you may even answers. In last, I think 10 years, the management of Empyema has changed entirely. A lot of people, or a lot of pediatric surgeons in India have started doing thoracoscopy. So we may give a little more weightage on that, on discussion, but unless you know even the pathophysiology, etiology, organisms, which antibiotics will help, I think if you know that, then the treatment or management of the Empyema would be easier. And the first part is, more of clinical investigations, and the second part would be on the management. I will hand over mic to my panelist, who will give a self-introduction, and then we'll continue further.
Good morning, everybody. I'm Dr. Ketan Parikh. I'm a pediatric surgeon from Mumbai, and I have been active into laparoscopy and thoracoscopy for the last about 12 years.
Good morning, friends. I'm Dr. Indira Shah. I'm a pediatric surgeon from Ahmedabad, Gujarat. I am interested in laparoscopic surgery for nearly last 15 years, and many cases has been published in the journals as well.
Morning. I am Dr. Jagdish Chinnappa, pediatrician at Manipal Hospital, Bangalore. My primary area of interest is respiratory medicine, so that's why I'm here.
Good morning. I'm Satish Rao. I'm a pediatric pulmonologist from Birmingham Children's Hospital, UK. So I work in conjunction with the thoracic surgeons there looking after children with Empyema.
I'm Dr. Narendra Kumar. I am from Nilofer Hospital. I am HOD of the department, and we started doing VATS for the past 2 years.
I am Dr. Vikesh Agrawal. I am Associate Professor in Medical College, Jabalpur, and I have work on CT staging for the staging of Empyema, for which I have been called here. Thank you.
I'm Dr. Dasmeet Singh from Pune. Rasik was 1 year senior to me, and when he came back from the US, he was the one who pushed me into laparoscopic surgery almost immediately. So I'm really thankful to him. Thankful to the organizers to having me here.
Good morning, everybody. I am Dr. Abraham Maman, pediatric surgeon at Malabar Institute of Medical Sciences, Calicut in Kerala, with interest in laparoscopy and thoracoscopy for the last couple of years.
I think most of you know what is Empyema thoracis. Is collection of pus in the pleural cavity, usually secondary to bacterial pneumonia in most of our patients, but there are other causes like tuberculosis, perforation of esophagus, etc. But today's discussion is mainly on Empyema thoracis secondary to bacterial pneumonia. Next slide, please. There are, okay, you have pointer, but next slide. Next slide. Next slide. Now, I will ask this question to Dr. Jagdish. What do you think what is the incidence of effusion or pneumonic effusion in, not in Empyema thoracis, but in pneumonia, what is the incidence of effusion?
Well, the incidence of effusion is probably universal in pneumonia. Once you have a pneumonia in adjacent to the pleural space, you will have some degree of effusion over there. It's a parapneumonic effusion. The degree varies. You may get a very small effusion to a very large effusion depending on the severity of the pneumonia. True empyema may be much rarer, but effusion is very, very common with pyogenic pneumonia.
Okay, I mean, if you read the textbook, it would vary, but in one of the book, it is written 50%, and which is, I think, what Dr. Jagdish says. Can you just click, you will have to continuously click as and when I say, because I think the control we may not have. Next slide, please. Dr. Suresh Rao, in your practice in UK, what are the common organisms?
Our most common organism is pneumococcus. What happened in 2006, 2007 is this the Prevenar was introduced, which has 7 serotypes of pneumococcus into routine practice. We have seen an increase in incidence of empyema year on year. And there may be 2 reasons for that. One is probably what the Prevenar is doing is it's selecting out the the empyemogenic strains of pneumococcus. Because most of the strains of pneumococcus that cause empyema are not covered by Prevenar. So that might be one of the reasons. But the other interesting piece of work is the association between viral infections and empyema. So it may be that if you have a viral infection that precedes a pneumococcal infection, probably have more high likely chances of developing empyema. So the main organism for us is usually a fully penicillin sensitive pneumococcus.
Okay, in your practice?
I think I agree with Dr. Satish that the predominant organism still is the pneumococcus, but we have seen staphylococcus as another major organism in Bangalore. And recently, one of the disturbing trends has been the prevalence of MRSA, the methicillin-resistant Staphylococcus aureus, in the community. We are not talking about the hospital-acquired bug, but the community-acquired MRSA is becoming a very, very significant organism. And I think it's very important to culture the space, otherwise you will miss this diagnosis totally.
Like what he said, with the vaccination for the pneumococcus, have you seen the decrease in the incidence of empyema or increase or same?
The problem with the Prevenar in India is it's not universal. It's very, very selective, and it's given to such a small proportion of the population that really I don't think it would make any kind of a community difference like it has done in the UK or the US. Commenting on what Dr. Satish says, there is now a 13-valent which has been introduced in India, which is a little more advanced thing, and which covers also what is called as the 19F, which is one of the organisms which produces empyema. So we don't know, unless it is used as a mass vaccine, you cannot say whether it makes any difference in the incidence of empyema.
One of my pediatrician who normally refers all empyemas to me, we had discussion and he said the incidence of empyema has gone down. It may be in a selected population in metro cities in upper class, maybe. This was like, he used to refer me at least 4 or 5 patients of empyema every year in the beginning of this decade, means 2001 to maybe 6, 7, and then maybe 1 in a year. And when we discussed, he said probably it is because of vaccination. So whatever, in future it may even go down further. Can you click, please? So these are the common organisms where H. influenza, Pseudomonas anaerobic, in particularly in sick and hospitalized patient, and Staphylococcus aureus particularly in less than 2 years. But what we are seeing is more staph now than what we used to see pneumococcus. At least in my practice, it may not be universal. If you go to the smaller towns, it may be the Streptococcus may be still the main organism.
Yeah, it was regarding your previous point. Even in Pune, the incidence of empyema has gone down considerably, and it's probably not because of Prevenar. I think it's because of better treatment of pneumonitis.
Next slide, please. Etiopathogenesis of empyema depending upon organism. Anybody will like to answer this particular question? Mohan, where is Mohan? Mohan is here. You want to say anything? Sorry, Abraham. Maman. Etiopathogenesis of empyema. What I want is basically, there is a two different type of pathologies. One is in pneumococcus and second is in the staphylococcus. In both, basically, the pathogenesis is different in the sense in staphylococcal, what you develop is sort of an abscess, small abscesses which will coalesce and form either pneumatocyst, and if it ruptures, it gives rise to pneumothorax. And the other entity is pneumococcal, where it is more of pleural disease, where you don't have pneumothorax, you just have empyema, which is effusion, means no pneumothorax, no fluid level. Okay. So when we see an X-ray, you know exactly which organism you are managing, and accordingly you give whatever antibiotics and other things. So that is what we'll say etiopathogenesis of empyema depending upon the organism, because ultimately in the management there are two important aspects. One is antibiotic, proper antibiotic, and second is the proper drainage. Now depending upon the organism and stage of the disease, all this will vary, but these are the two important things, and you need to reach to the conclusion where you choose a proper antibiotic and you use a proper way of drainage, and all these factors will help you ultimately coming to a particular point. Next slide, please. So this is what we were saying. Is it possible to shortlist the possible organism by looking at the clinical picture? So basically, if you have pneumothorax, pneumatocysts, then you can come to the conclusion. Here I like Satish. Can you Satish, na? Satish.
In terms of the clinical picture, if it is a streptococcal, our experience has actually been that they present with septic shock. They are more likely to present in shock, requiring fluid boluses, and they are pretty sick, pretty desperately sick children. For staphylococcal, I guess the clue is if there is any cavitatory type of lesion that's visible on the X-ray. And again, the timing of that seems to be fairly variable. And as you rightly said on your slide, less than 2 years of age, Staphylococcus staph aureus will be it will be top on the list. With pneumococcus, it has tended to be more an insidious onset. So in our experience, what has happened is the child has been unwell for a few days. They have been to the general practitioners, they have received probably a course of antibiotic, then subsequently the temperature hasn't settled down. And in our experience, pneumococcus has caused quite a bit of pneumothorax bronchopleural fistulas as well. In fact, predominantly, in fact, staph, although we have seen cavitations and lung abscess, we haven't seen so much of bronchopleural fistulas, whereas with pneumococcus, we have seen quite a bit of that, and trapped lung and so on and so forth. And the other thing about staph is this PVL staph, which is the methicillin sensitive Staphylococcus aureus. And this PVL producing staph, which produces a toxin, tends to present again as a septic shock, but it tends to cause quite a bit of vasculitis, almost like a meningococcal septicemia. And we've had a handful of cases where the vasculitis has been so severe that it has resulted in infarction of extremities. I can remember a 2-year-old girl in whom we had to do a bilateral below knee amputation, so she was pretty sick. And the thing about this MSSA staph or PVL staph is that flucloxacillin alone is not enough, because it results in quite a rapid release of toxins from staph, and it is quite often important to use something like clindamycin, which basically it is more effective. Fluclox alone will probably result in more widespread disease. So yes, it is possible with the way they present to make out the organism. But I guess one thing that we know in pediatrics is that you can trust anybody, but you can never trust a child. So you've always got to keep an open mind. So they always prove you wrong. They have this habit.
Jagdish?
I agree with most of the points. There's one additional point which I wanted to make is that if you look at the necrotizing pneumonias of the lung totally necrosis, usually it is a pneumococcal disease.
Okay.
And if you find abscesses which are fairly discrete within lobes, then you probably would be dealing with a staph. That's the other point which I wanted to
Okay.
I think I would totally agree with that.
Okay. Please.
Even our experience binds out exactly the same. Yeah.
Now, when it is pneumococcal, in our practice we find more often it's a pleural disease, means early loculation, thick peel. However, in staph, usually peel we find which is a little thinner and usually is associated with pneumothorax. This is personal experience. So depending upon this, if you are finding of pneumatocyl, Dr. Anirudsha, what do you think?
See, with pneumatocyl, you're likely to have a pneumothorax. Organism, I think it is staphylococcal only. Even organism is difficult to on culture also. So to be precise on organism is very difficult.
Sometimes it may be gram-negative,
Klebsiella. Because culture positivity is also very low.
So pneumatocyl probably staph and Klebsiella one should keep in mind. Next slide, please. Next slide. What are the stages of empyema and approximate duration? Vikesh, you will like to answer?
Basically, as per the classification of American Thoracic Society, the stages of empyema have been divided into 3 stages: exudative, fibrinopurulent, and organized phase. And the duration of the stage is basically based on the clinical symptoms such as fever, cough, history of pneumonia, and the stage exudative lasts for about 6-7 days. And then up to about another 4-5 days, the fibrinopurulent phase lasts till 11-12 days. And thereafter the empyema gets organized and the peel starts fibrosing, and the stage is called as organized phase. So basically this duration of the phase a lot depends upon the organism and the disease process and the immunity of the child. So that is a very varied duration, and clinical stage is very difficult to identify as such, because the history is very subjective. It depends upon the duration of the symptoms told by the parents.
So this staging and duration, in my opinion, it's only arbitrary. So we can't tell what is the exact duration, which stage like. It's all overlapping and it's a continuous process. Some studies say the time taken for fibrin septa to form is 72 hours. That is why they don't wait more than 4 days. If it is less than 4 days, it is a non-organizing empyema. More than 4 days, it is organizing empyema. Some classifications are there, only 2, organizing and non-organizing.
In a way, you're right, because we have seen the trend over the last 15 years. What we used to get earlier was what Vikesh was saying, that there were stages going 7 to 15 days, each stage would last around that time. But now, after a lot of antibiotic use or misuse, the stages have gone completely haywire. And nowadays, history of 2 days also, sometimes we start getting multiloculated empymas. So that's what is surprising. But on an average, if you see, the multiloculated stage comes after about 7 days. I think it's most important to differentiate like that, rather than try to give some kind of names to each classification. I think it should be what is amenable without surgery and with surgery.
Mike is here. Jagdish, you get almost 40, 50, 60% of the patient of pneumonia, some kind of effusion. Now when you will think that it is going into stage of empyema and you need a surgeon, before that let Deba give whatever comment.
You are saying these 7 days or 4 days. So which day you counting as day 1? And what is the criteria?
That is the answer which he is going to give now. So when he thinks that patient has developed instead of effusion empyema, and that is the time you will call it as day 0.
I think the first day should be taken as a day when the child has symptoms referable to the lower respiratory tract.
Absolutely.
So you should, if the child has got an upper respiratory tract and started off with a cough cold, that cannot be taken as day 1. Day 1 should be the day when the child has tachypnea, has probably chest pain, has deep cough, has breathlessness, drop in saturation, any of these. When you have a clear-cut indication that this child has a lower respiratory infection, that should be probably taken as day 1. Now the next question you asked is when does a fluid you would say is empyema, when you would say is just a effusion. This distinction is very difficult to make on a clinical ground. What you need to do is probably look at the fluid, look at the amount of fluid, whether it is increasing or not. So a serial follow-up. And second thing, if you find septation, obviously you are not on a simple effusion anymore. You are on an empyema. But before that, to say whether it is an empyema or not, you need a tap. And I think that's the first thing you would do if you found fluid in the chest. Once you do a tap, then you probably could say what it is.
So most of the time, if you see effusion, you will tap it.
Yes, most of the time, yes.
Okay.
Significant effusion. If I find a very small effusion which is difficult to tap, obviously I won't do anything about it.
Okay.
So at this stage, it's difficult to know is a massive consolidation or is it an effusion?
You get a sonography.
Yes, ultrasonography is the best method to sort out whether you are on to this or that.
If it's thick past, the ultrasound will not show.
Then CT will show.
Or when do you do a CT now? Thing is, everybody jumps to CT straight away.
No.
Nobody. You get a call, big massive consolidation. Child is actually tachypneic, febrile. No, if you are missing an empyema, you are doing a Himalayan blunder. But at the same time, you cannot go and pickle a consolidation. I have had this problem. I would like to share others.
Yes, sir, I agree with you.
Can I just comment on that? Probably we'll be coming on that. But in our experience, ultrasound is far more reliable in early cases. And in late cases, CT is far more reliable. So, no, that's a very subjective thing.
Many times, basically what you may see is opacified chest, and in that you have to do minimum is sonography. Whether it is pneumonia, effusion, that confusion is there. And most of the time, good sonologists can differentiate between the two. And then, depending upon the amount of fluid, you may tap, you may not tap, you may tap USG guided, you may tap without that. Next slide, please.
Excuse me. About the amount of fluid you just mentioned, so what is the amount which you call significant, and when you decide to intervene and do a tap, or what exactly is the amount?
Abraham?
I don't think you can put a figure to that amount. It's a very arbitrary thing, but you have to go more by the clinical status of the child. The sicker the child is, obviously means he's got a bigger problem, which means he needs to be intervened earlier. So I wouldn't say you go by 50 ml or 60 ml or whatever the ultrasonologist says. This supported by the status of the child needs to be decided on the timing of your intervention. And to my experience, actually, a good sonologist is able to make a fairly good differentiation between consolidation and effusion, loculation, and even the consistency of the fluid. And therefore, I think I would still strongly back for ultrasonography as one of the first non-invasive diagnostic modalities, and based on that, go in for a diagnostic tap or a thoracoscopy as indicated.
I'm Ramesh Reddy. I practice adult thoracic surgery. It's important that you interact with your sonologist. Initially, when you ask him to do an ultrasound test, he looks at you, why do you want me to do chest ultrasound? And then over a period of time with interaction, he says some findings, and you go back after your ICD or thoracoscopy or thoracotomy and tell what your findings were. Over a period of time, you develop a rapport, and he also develops his skills, places his interest, and we come to a stage where you can trust what he says and he will believe what you say, and you can trust each other. It's not in the initial period. It's over a period of time your sonologist also will learn. Most of the time it's a good machine, and most importantly, man behind the machine that is required for the sonologist.
I think
it takes time.
He has brought out a very good point, interact with the sonologist, because they are dependent upon us to give what we have found. So I think it is very important.
Very important, because they are not clinically trained. They are in investigations. So unless you tell them what you want and what to expect from them, the future ones will be difficult. But once you do that, I can guarantee you the results will be very good.
I just have a very small point. When I passed out from Bombay, and where we used to do ultrasound as the first investigation for empyema, and beyond doubt it was clear that ultrasound is the best investigation for the first assessment. When I went back to Jabalpur, there we get a lot of late presentations. So here one point which is very important, that if you get a child who is having early presentation, ultrasound definitely is the best investigation. But if a presentation is late, like ICD has been put by a general surgeon or someone else, and patient has been referred
We'll
to
come to that later on.
I think the key here is a good clinical examination and a good follow-up. I think at the end of the day, when the child comes to you with a severe, what looks like an empyema, what looks like a probable consolidation, the first step is to stabilize him, give him adequate fluids, give him the adequate antibiotic, maintain his oxygenation, and repeat an ultrasound if required in 24 hours. You're not going to miss anything. And at the same time, I think a good clinical evaluation will definitely differentiate between pleural fluid and between a consolidation. If the air entry is diminished at a point in time, I'm definitely sure that it is an effusion. I don't expect an air entry to be diminished in a pneumonia. So I think a clinical exam, good clinical evaluation will clearly tell you whether you're increasing with your effusion or not.
Sure.
Yes, sir. Yes, sir.
So-called consolidation which was seen by you and the pediatrician.
Yes, sir.
No, how many of such cases after 72 hours have gone into an empyema?
Lot of them, plenty of them.
So then the patient will say, you are there from day one, you are seeing, how is this consolidation going on? Why haven't you given effective treatment for consolidation?
The effective
so what can you do to prevent an empyema? Is a bronchoscopy indicated at that stage? To get the right organism, give the right antibiotic. The problem is the infectious disease doctor wants to give, he wants some culture. He says, I want to give the right antibiotic. You give me some material for culture. At that stage, what do you do?
So I will tell you what is standard practice in my institution. The standard practice
can I interrupt? We will come, I mean your questions will be answered at some point. Let Satish, what investigation you will do when the patient of pneumonia, empyema, whatever, that comes to you?
Sure. I think just going back to the point of, well, how many of those consolidated lungs can develop into effusion? We have seen in our institution a child who is presented with what looked like a lower respiratory tract infection, given effective antibiotic cover. But still, we have not been able to stop the progression of the disease. They still develop. I think it is mostly to do not so much with the antimicrobials that you choose. It's the host versus the microbial interaction. That is there. Now, in our practice, as the point was made here, quite a lot of our referrals are late referrals, and in some ways the National Health Service, NHS, is slightly primitive in certain aspects, and in our institution we are the supra-regional center for West Midlands, and the beds are pricey. We never have enough beds, and the pediatric thoracic surgery does not happen anywhere in the peripheries. They all have to come centrally to us. So that results in quite a bit of delay. We could have sometimes children waiting for 2 or 3 days to come to us. And they tend to be sort of more late presentations. And in those late presentations, we've definitely found CT more helpful. But in the early presentations, I think I would still say, yes, we would check a full blood count. That would be a blood count to make sure that this is what we are dealing with. Because we've been caught out in our series about our incidence of malignancy in children presenting as empyema was between 7 to 10%. So we find full blood count quite an important thing just to confirm infection. We measure an acute phase reactant such as C-reactive protein in our practice, so that then you have a baseline to see whether the child is improving or not, and especially if we have a consolidated lungs on chest X-ray or a minimal fluid as part of your clinical evaluation, you could use repeated measurements of acute phase reactants. Is that we do a blood culture, but as you rightly pointed out, the blood culture is very poor. The pickup on the culture positivity is extremely low. It's less than 30-40%. We have tried using urinary pneumococcal antigen, and we've had some success with that, but our main problem with urinary pneumococcal antigen is that is it specific enough? I think that is sometimes the question we ask. Whether it is, it can be non-specific. Sometimes even children may not carry pneumococcus, so they might carry it in their, upper airway, and we may still be able to detect that. We've talked about chest X-rays. And I guess this other investigation, early empyemas is I would certainly agree, on ultrasound examination.
What other cultures, if at all, blood culture, any other culture?
We don't, I mean, when we get the pleural fluid, when we get to that stage, we do send off for cytology. That is based purely, I mean, none of the other centers have replicated our experience. I mean, we've had 7 to 10% malignancy. And we also send off for a pneumococcal PCR. Because quite a lot of the times, 9 out of 10 times, we don't grow pneumococcus in blood. But from the pleural fluid, the pneumococcal PCR is quite often identified. And that is a fairly sensitive and a specific test.
We also used to do the antigen level in the pleural fluid to check for the common organisms. We stopped doing it now, but that's another test which has been advocated in case you can't get a culture positive.
Any IgM or anything, pneumococcal, immunofluorescent on?
What about procalcitonin level? Nowadays we, do serum procalcitonin. That's like that seems to help quite a lot.
The procalcitonin is again more like we've used that as an acute phase reactant, but I must say we've not used it so much for empyemas. It is mostly children who are pretty sick and on ITU majority of the time.
So I think apart from the routine investigations, the specific will come is the fluid aspiration and then you decide further. I think everyone knows over here how to do aspiration. We'll not go into that, but we'll go further. What would be the findings which will, Ketan, you like to answer?
What's the question?
On fluid, what you will like to do? Aspiration, fluid investigations.
Yeah, I think aspiration fluid, of course, the routine cytology and this thing, and we get a culture done. As far as my line of management is concerned, I think, I agree with most of them that the basic investigation is chest X-ray, and usually, yes, you can decide that there is some fluid or there is no fluid. Next is, of course, an ultrasound to differentiate whether it is fluid or not. My decision to do a VATS or not to do a VATS is based essentially on fluid examination and ultrasound. If I do a CT only as a pre-VATS measure, that means not to decide whether to do a intervention or not, but when I have decided to do an intervention, then I do a CT, because then I want a three-dimensional. When I say three-dimensional, means the CT gives me an accurate this thing that where the loculation is and all that. Yeah.
CT. Yeah.
If the pleural fluid contains bacteria under microscope, there is no need to do the further test to differentiate whether it is a fluid or a pus. But once there is no bacteria under microscope, the most important thing is the WBC count. It is not there. That is why I wanted to point. Should be more than 10,000 WBC. It goes in favor of a pus purulent. All the other points are already mentioned there.
Yeah. So you do cytology and chemistry. In cytology, WBCs, and on chemistry, blood glucose, pH and LDH levels, and you do gram staining and culture. Again, this is gram staining may pinpoint the organism, and you can start the antibiotics accordingly or change the antibiotics accordingly. Next slide, please. And IgM streptococcus, which was been done at our place. Next slide. These are all cultures which can be sent, and that may help you to do whatever, change the antibiotics. I don't know. In your experience, Jagdish, does this help in any way?
Yes, it does. We routinely send a blood culture and, if possible, a sputum culture. Both these are sent, and the pleural fluid, of course. All three will be sent anyway. And depending on that, it definitely helps. The blood culture, as Dr. Satish mentioned, the sensitivity is around 30%, because most of the patients we would have come already treated with some antibiotic.
And in rest, what would be
the pus culture also gives a reasonable amount. We have found a huge amount of staphylococcus and pneumococcus. These two organisms are definitely culturable, but other organisms no.
Okay.
Sputum is not done routinely.
Okay.
Only when we are suspecting an unusual organism that we will draw out a sputum sample.
Okay. Next slide. I think USG findings, anybody you will like to say what all you will like your sonologist to tell you?
Basically, the USG
Yeah.
How many of us would really look for tuberculosis also at any
Okay.
A lot of time we have tuberculosis which gets secondarily infected, or you have an infection on top of a tuberculosis. The fluid that you aspirate is thin fluid, and you look, there's always a point of debate whether
Okay.
it is tuberculosis.
Jagdish.
So do we routinely do it for tuberculosis or not?
Routinely we don't. We look at it under two circumstances. One is if there has been unusual, that is, this child has presented with a history of illness for a longer than an acute illness. That is one situation. Second situation, if the child appears probably immunodeficient, like for example is HIV or any of the other ones. And the third situation is if you find lymphocytic predominance in the pleural fluid, then we would definitely look for tuberculosis as an etiology. Yeah, so you need to know the pattern of the WBC, whether it's a neutrophil or a lymphocyte.
Will you go for anaerobic culture?
In a child who is not responding, yes. Not routinely.
No, when you do a first aspiration, will you ask for anaerobic both?
Depends on the clinical situation, sir. Supposing I found this child come to me from, let us say, an acute history of an ARI going into a pneumonia with a fluid, then I may not ask for an anaerobic culture. But an anaerobic culture, supposing this is a hospitalized patient who lands up with an empyema, I would definitely ask for an anaerobic culture. Or a child who has a setting for a immunodeficiency, then yes. Or an aspiration, something of that sort.
So unusual empymas, I think a whole battery of investigation has to be done.
Okay.
While routine cases, we may go ahead with the routine cultures and routine blood counts.
Regarding going back to culture, I want to ask one more thing. That often we have seen pneumonic effusions. That is the time you do the tapping, the report turns out to be no growth, as you have already mentioned. Now, we continue with the same antibiotics. In spite of that, which is showing no growth, that means it has to be effective. In spite of that, these kids do progress towards developing an empyema. So where do we stand? What is the importance of tapping in such a case?
See, as Jagdish has already mentioned that developing empyema depends on the host and the bacteria.
Yeah, but many a times you find that
in spite of antibiotics, based antibiotics, you do develop empyema.
But there is something
and that cases require some additional treatment apart from your antibiotics. That I think will come to.
I feel Dishant.
I have.
What are you going to do after aspiration? None of you have mentioned anything. Are you going to keep quiet or do something about it?
I have two questions.
Sir, we will come to the management part. Means aspiration we have done for the diagnostic part. The management we have not yet come. There are two aspects, antibiotics and drainage. We are still on the...
Antibiotics also is a management.
Yeah, so we are still on that aspect, not the surgical drainage. Now after aspiration what? That will...
Do we get blood on aspiration?
Blood on aspiration? Not.
Hemorrhagic fluid.
Sir, I have...
The consolidated blood, or it's a dengue fever. See, these sort of things we come in practice. Consolidated lung is there, or it was an effusion, child is sick. Dengue also comes like this. Then you tap, it's hemorrhagic effusion.
Now, I mean, I mean that is in a consolidated lung. If you put a needle, you may get, or in less stage. Okay, let's go to the standard presentation. Now, I mean the investigation.
Dr. Rashid,
yeah.
I have two questions, Dr. Basu.
Yeah.
Yeah, one is that after you have done a tap,
Yeah.
what are the indications which put you to an intervention or a tube? Second is, how many of us do LDH and ADH studies in the pleural aspirated fluid to decide on whether we will go on conservative and or intercostal drain, or we will go for interventional surgery? Do we depend at all on LDH and ADH level in the pleural fluid for
Okay. Anybody?
Does protein evaluation of the aspirate?
I think that was already put up.
So protein means it is a part of the chemistry. If you have more than 3.5 gram%, then yes, it is suggestive of empyema, exudate, otherwise it is transudate. So that is the part of chemical analysis, and it is, I think, routinely been done everywhere.
I don't think it was shown in this.
No, it was not there on slide. I agree with you. These were the finer aspects.
I just want to make one small comment?
Yeah.
Just to add to the organisms, since we are discussing unusual infections, we had 2 diabetic patients who had mucormycosis. So I think not only should we think of antibiotics, but sometimes it may be a fungal infection. And CT is often useful in that because there's a vascular invasion in mucormycosis also.
Yeah, quite right.
Okay, let's go.
I think everybody is getting very impatient and everybody is getting into the management segment. Is that
let's quickly finish off.
Why don't you just hold on to your questions for a while so that we can get to the management part and then we'll, because this is going to be never ending.
Anybody, if you can you highlight on sonography some of the things have been already discussed?
Okay, so
let's go ahead.
Yeah, if you take the way a pneumonia happens and then goes into an empyema, so what you're looking at is a patient who is having fever or a valri. It goes into, he has a mild response and then he gets a recurrence of fever and then you're suspecting empyema and then at that point you do an X-ray test, again you're suspecting some kind of empyema or a effusion. Then you do an ultrasound and a sonologist has to tell you whether it is solid, whether there is fluid, what's the consistency of the fluid, whether it's thin, thick, whether there are any septi, what is the location, because if it is free fluid or whether it's loculated fluid somewhere and higher up. So those are the findings which we need from a sonologist.
Okay. The next investigation which was discussed a little bit was CT scan. Vikesh had done some work on that. Let's listen from him.
May I have the permission of Dr. Rasiksha to show my slides? Actually speaking, before I go to the CT scan, one drawback I ultrasound. If the peel is very thick, or patient has undergone ICD, which has instilled some amount of air inside or cases of pneumothorax, and there is narrowing of the intercostal space. So it is the limitation for the even a good ultrasonologist to give information. So basically we have conducted a study, retrospective study on our group of patients, about 120 patients, and we found that our ICD failure rate, if we assume that ICD lasting for more than 7 to 10 days, was as much as 60%. And need of open decortication was very high in our group. So we had to search out certain investigation which would allow us to detect these cases quite early. So we came up with this staging system, which is basically the criteria have been divided into 2 groups, primary group and the supportive criteria. Primary criteria is you may find pleural enhancement that suggests that there is inflammatory pathology in the pleura which has resulted into thickening of the pleura. Second, there may be thick enhancing pleura, like there may be thin enhancement, there may be thick enhancement as shown in the second image. And third, as quite rightly pointed out by Dr. Dasmeet, is the loculation. So if you find any of these 3 findings, this suggests that the empyema is late. So rather than dividing the empyema into 3 stages, it is better to divide the empyema into early stage and a late stage, which has practical implications. So this is the empyema where you will find pus also on aspiration, you will find bacteria also, everything. But there is no pleural enhancement, there is no loculation. So this patient is having early empyema and is suitable for intercostal tube drainage. This slide should come later on when we go discussion on the VATS versus open. The thing which need to be pointed out here is, if you come across a case of empyema in which ultrasound findings are not very confirmative or ultrasound is not very confident to tell that what is the stage of the empyema, then in those cases it is always better to go for the CT scan. To add to Dr. Parikh's comment, that sometimes it is useful to decide what mode of intervention you need. Like if you go for VATS, in late cases, very late cases having very thick peel, then there is possibility that you may have a very high failure rate of VATS, especially for those people who have recently started doing VATS. So this gives an information, like we have compared the thickness of the peel also, and these sorts of peel are better treated by
open decortication, and those thinner one are better treated by VATS. So this is the statistical values. Visceral peel thickening more than 2.6 millimeter, parietal peel thickening more than 3.2 millimeter, presence of loculation and pleural enhancement. These are the things, if they are, any one of them are there along with the collapse of the lung, this suggests that it is a late empyema and needs some sort of intervention more than intercostal tube drainage.
Thank you, Vikesh. Now, I think we have completed the investigation part. Now, depending upon the investigations, we will come to some conclusion and then go to the management. Now, Jagdish, if on investigation you have done fluid aspiration, you have got the cytochemistry results which are suggestive of empyema, and on sonography you think thin fluid is there. What would be your suggestion to your pediatric surgeon, or when you discuss what conclusion or what plan you will make?
I think the key to management are three issues. Issue number one is supportive. First, see that the physiology is corrected, that the child is well oxygenated, temperature is normal, fluids are maintained. Number two, the correct antibiotic should go in. That's the key thing that we need to do in. And in a child where we don't know the organism, it's good to cover for both for pneumococcus as well as staph. Our standard policy is to start in a sick child. We normally start with either ceftriaxone and vancomycin as a combination, or ceftriaxone and cloxacillin as a combination to cover both pneumococcus as well as staph. That will be the next step. And third step would be to get adequate drainage of this fluid. And for that we involve our pediatric surgeon pretty early on. We used to put in the tubes ourselves before, but now we don't. We call our pediatric surgeon colleague who will then put in the tube with ultrasonic guidance into the right place.
If it is thin fluid, any panelist has any experience that by just aspiration you can get away? Anybody? Or even from audience, means any one of you just treat empyema with aspiration?
Sir, suppose we get cases from pediatrician. They keep on insisting that why don't you just aspirate? Sometimes it happens that why you are putting ICD, it is pleural effusion, why don't you just aspirate? I have done few, and what problem which I have encountered thereafter is they develop pneumothorax sometimes. And then you are in trouble. Like patient develops distress because of pneumothorax. So it is always better to put a thin tube rather than to aspirate. It may be therapeutic, but this is the problem.
Okay, so by and large I think nobody is in favor of aspiration. Very rarely I think you may get away with one aspiration, the entire fluid is drained. Only in one case, if at all I remember, in our patient. So basically it will be minimum of intercostal drainage. That is what it appears.
We have formed a protocol where the minute you prove that it is exudative effusion, you put in an ICD, even if it looks thin. The minute you prove that it is exudative, that means your proteins are more than 2.5, your sugars are less than 40, okay, and your LDH is more than 1000. You just put in an ICD, and that reduces the chances of needing VATS.
Okay, if you have to choose the tube, whether you will choose something like pigtail or standard Portex, large size, large bore, intercostal drain.
I prefer a wide tube, sir, because the drainage should be wide and we should reduce the bacterial load to the maximum extent. So wide bore tube is better.
Satish, will you like to answer that?
In UK, the what is more done is to put a pigtail catheter. Now the and use of urokinase, intrapleural urokinase. Now the initial evidence for use of fibrinolytic came from the adult studies, and there was a recent study that was published in, I think it was in Thorax couple of years back, which was conducted at Great Ormond Street, London. Now they randomized patients between the treatment for, once the treatment for drainage was done, one set of patients had a pigtail catheter plus urokinase instill. 12-hourly urokinase, 6 doses in total. And the other group underwent the VATS procedure, video assisted thoracoscopy. Great Ormond Street Hospital has very similar referral pattern to ours because it's a tertiary hospital and they get patients from all over, and perhaps not very early, but it's of intermediate or late stage of disease. And what they showed was the primary outcome was they looked at the length of stay in the hospital. The length of stay between the two groups was very similar. So they concluded that putting in a pigtail catheter and instilling urokinase essentially is as effective as VATS procedure. And the other advantage of pigtail they felt was that it was less painful and it facilitated early mobilization and that kind of thing. But there was a failure rate of about 10%. 10% of children with pigtail will go on to have decortication, and that's the UK experience.
I think there are a lot of controversial reports on the subjects, and that was the reason why I asked this particular question, because in pediatric literature, if you read, most of the time you will read pigtail, and particularly if you are treating in early stage along with fibrinolytics, yes, it would be helpful, but otherwise surgical books, it is always wide bore intercostal drain. Now tell me in which patient you will do, we'll go directly to VATS because I think we have another 20 minutes or so to discuss. Patient is empyema, either you put pigtail or intercostal drain. Then we have surgical drainage like VATS, open thoracotomy and rib resection and cyclical irrigation and many other things. So let's come to VATS because I think most of us are interested in that. I will ask Ketan what his preference would be.
See, as I was just saying that usually the aspiration is done by the pediatrician, or sometimes so I would first have got it done, and the next thing is sonography. If the sonography and both these things are showing that there is a reasonably thick pus, so I prefer a primary VATS if it is possible. My argument in favor of primary VATS is that you are removing everything, all the thing you are identifying. There may be some loculi which has been missed by the sonologist, but that also has been taken care of, and I am able to give a very good lavage under vision, and maximum bacterial load is removed, maximum fibrinopurulent load also is removed when I am doing a primary VATS and giving a lavage. If the patient has come late to me, that means he has already come at a stage when so loculation has been already done, so that means possibly somebody has already put an ICD, somebody has already done a couple of aspirations. So then of course then you do a proper regular VATS, and this is a time when I would prefer to do a CT scan beforehand, because I want to see where the loculation of the pus is, because earlier days I have gone purely on the basis of ultrasound inside, and I have missed out a particular locule because it was not seen, and there was another locule at some other and that I have missed out. So I thought that I have removed all the loculi, but there was another locule, and that is the time after that I have realized that we should not miss out, because the ones which are likely to miss out is the diaphragmatic area. The diaphragmatic area, sometimes you can miss out a locule if you have not done a CT scan before, and that is an area where you can miss out locules. So if you have done a CT scan, you have identified all those things. As regards thickness of peel, I think I have never, I'm sure that I have never gone in for a primary open decortication, and almost in all the cases I have managed to get a fair degree of this thing by VATS. Now it's a possibility that even in those patients where there is a narrowing of the chest wall, narrowing of the intercostal space because of a thick peel, what you do is that you may not really, in a child I'm talking of obviously, even you may not be able to get the entire parietal pleura, thick parietal pleura out by VATS. But if I am able to just remove the visceral pleural component, remove all the fibrinopurulent exudate, I am able to remove the loculi, I can see lung expansion. And if I can see fair degree of lung expansion, I don't do anything more at that stage. In most of these cases, once the lung starts expanding, it is going to push out. Of course, on the parietal pleura, what I do is I just make some linear incisions on the thick peel so that the contraction of the thick peel, or rather than the fibrosis part of the thick peel, is reduced, so that you are facilitating lung expansion, you are facilitating chest wall expansion, and the child invariably pushes out his lung and chest wall over a period of time. So I have never gone for except in one case where I had a problem during the surgery. That means I just couldn't see, the bleeding was too much, and then that is the time when I had actually gone in for a immediate conversion. But otherwise I don't convert. I wait for a few days, and in almost all these cases the lung has expanded after a few days.
The aim of whatever aspiration, ICD, VATS is lung expansion. You want to achieve the lung expansion. Now there are many ways. One is primary VATS. Here they put an intercostal drain every time and then do whatever further required. Now my question to Dasmit would be, in case if you put intercostal drain, how you will manage the patient further. Before that, I'll just show you the clip where if you are doing early VATS, what you will find, and Abraham, can you say how will you do the procedure? Primary VATS if you are doing. Please.
I have a very low threshold and I tend to go in fairly early once a diagnosis of empyema is made, because at this stage it is much easier to deal with these thinner fluid, the loculi which are not too well formed.
Steps of primary VATS.
Okay, the procedure is done under anesthesia. I put it in a modified lateral position with the side obviously which has got the empyema up. I do not use a Veress needle to produce this thing. I go in straight. And if I sometimes do ask my ultrasonologist colleague to mark out an area from where I can enter into the space with relative safety. The first thing that you do once you enter into is to make sure that you have adequate vision by establishing a place where you can get enough of pleural cavity to work in. There are two ways of doing it. You can enter in through the actual pus cavity and then work your way into the normal area, or enter into a normal non-pus bearing area and then work into the abscess cavity area. Once you have entered the pleural cavity, you need to make sure that all the loculi are broken down completely and under vision. As far as possible, open out all the loculi, the cavities, drain all the pus, make sure that you see the lung actually expanding. Once the lung is freed up and expanded, then you remove as much as of the peel, and a good thorough lavage will complete the procedure. ICD tube I do put in post procedure, but I leave it only for a maximum of 48 hours. I'm able to, in most of these cases, remove them quite early, and the patient can be mobilized and sent home relatively fast.
How many ICDs will you put?
Usually only one under vision. I put one from somewhere entering the pleural cavity low down and going right up to the apex of the pleural cavity. Very rarely do I put more than one.
When you will put two?
If I find that there is a very thick peel or difficulty in releasing the entire lung, especially the upper part, then maybe I'll put a second one in the apex.
Anyone else will like to answer?
I think I have always put only one ICD. In a child, it is not required to put a second ICD on the second intercostal space, because most of these children are supine one, so that means the air can come out from anywhere. Secondly, as the lung is going to expand, it is going to push out air from wherever it is there in the pleural cavity. And if just a small amount of air just remains behind, also it is really of no significant concern, because that is going to come out. So I have put in a second ICD occasionally as a secondary measure if I have realized that after, that has been twice only, that after doing a VATS also, there have been reloculations which have formed, and that is the time when I realize that there is a reloculation on a chest X-ray after 48 hours, then I may put in a second ICD in two occasions, but otherwise I've never put in two ICDs on the first time.
I'll usually prefer...
Just one sec. This is a case of amoebic liver abscess which had burst into the chest. So what you are seeing is through the diaphragm, you are going into the abscess cavity. Yeah, sir, please.
If the pus is very thick and if there is significant air leak during your VATS procedure, I'll always prefer to put 2 tubes because one tube is likely to get blocked with the purulent material. In that case, you are likely to change your tube.
Yeah,
so it is better to put 2 tubes rather than 1 tube.
I agree with Dr. Anirudsha. At least I have put often 2 tubes, particularly whenever there is air leak. I think you don't lose anything by putting a second tube, and our standard thing is if air leak is present from the lung, whether it is iatrogenic or primary pathology, always put a 2 tubes. You don't lose anything by doing that.
Me and Dr. Bagri, we have done few cases wherein we have found that the part of the lung also is getting necrosed along with the whole empyema. So the lung comes as bits and pieces.
Yeah.
Then you start to have a lot of air leak. That is the situation where we have found. You should put 2 ICDs. And even after putting 2 ICDs, we have found a lot of still pneumothorax remaining, wherein you have to put low pressure suction and take it out.
BPF डाल दो.
So depending upon the air leak and the
center one
quality of the pleural fluid, you will decide about the number of tubes.
Like what Dr. Prakash Agarwal is saying, this is the video where you are basically seeing the necrotic lung, and Dasmit will like to tell something.
Can you show that other video? That it's very, very clear in that.
Okay.
Basically, how to tackle the necrotizing pneumonitis is what I've just shown in that. Ultimately, you have to debride the entire lung. You don't worry about the air leak, but how you have to tackle intra-op is because the air leak, all the bubbles keep coming in the way. Go to another area. So you start off with the necrotizing pneumonitis part, start debriding the lung. The minute that air leak makes it unmanageable, just compress the lung on that side, start removing from the other side. After some time that air leak has reduced. Yeah. So here you can see how that necrosed lung has to be debrided. Basically, you hold it with your normal open instruments and gently, by gentle compression, just go on removing that instrument. With gentle traction, whatever comes out is actually the necrosed portion of the lung. Okay, whatever air leak is going to happen is going to obliterate your vision. But at that point of time, you ask the anesthetist to blow lesser, and that also helps to manage the debridement. So here, once this air leak is obliterating your view, you go to another area, finish off your debridement from the other side, and then again come back to this area. So in spite of the air leak, you remove all the necrotic lung. And then once you've kept in ICD, I always use a single ICD, then it becomes a controlled bronchopleural fistula, and do slow removal of the ICD over a period of time. Once you feel that the remaining lung is expanded well, clinically as well as radiologically, then you start removing the intercostal drain, and the tract which it has already formed collapses and fibroses off, closing off the bronchopleural fistula. So we do about a ½ centimeter removal per day. So it takes about 7 days or so for that ICD to come out, and all of them have done very well without any need for thoracotomy at a later stage.
Like what Dasmit said, in necrotizing pneumonitis, if you are doing probably open surgery, you may do lobectomy. Now in this patient, if you do it VATS, like what he said, your hospitalization will be at least 8 to 15-20 days. Now the other choice is at this stage you do thoracotomy standard and do lobectomy, or debride it well and then close it. The choice is one of the two, either hospitalization of 15 to 20 days or open thoracotomy and lobectomy. Before that, I will say a couple of points. For the primary VATS is done under general anesthesia, lateral position. Usually monitor is kept posteriorly and surgeon stands anteriorly, because the peel or collection is usually posteriorly. If possible, you can have monitor even anteriorly, and if required, the surgeon goes on the back side. The assistant and surgeon are standing on the front side of the patient. Now on this particular necrotizing pneumonitis, I think some people, Sanjay, let Sanjay.
No, thank you. Just a couple of points I need to make. One is about the CT scan. While we are going, it is not unusual to have CT scan reports saying that there are intralobar abscesses or there is necrotic lung when it's actually in the fissure, and vice versa. There are instances where the report it's an abscess, but when you go in, it's actually within the fissure and the lung is doing well. So the CT scan, though is good, it has its fallacies. That is number one. Number two is when you are doing this kind of debridement, I think one bit of caution is there is a very, very high risk of stuff getting into the airway and compromising the opposite lung on which the child is being ventilated. So the anesthetist must be very, very aware about what you are doing and the risk that the child might actually have catastrophic airway problems during surgery.
I agree with Sanjay 100%. Okay, these are the problems, and even one more problem is the bleeding from this area which is being debrided. So
I wanted to say about this necrotizing pneumonitis. Again, my approach is that I do a staged VAT in that case. I have my first VAT, I just remove everything, all the infected material, whatever purulent material is there that I remove, and I go in after 4 or 5 days. I would have told the patient that I would like to, because once you have removed this, then the recovery potential of this necrotic lung is also significant. And trying and going in at the stage itself and trying to remove, I am actually scared of doing it, very frankly speaking. So that's why I would not do it at the primary stage. Stabilize the child, because the first time when I've got definitely a bad infected pleura. Badly, I have removed the infection, I have removed the infected component, and I would allow 4 or 5 days for this child to recover partially from this and then go in as a second stage rather than doing it at the first stage.
Sanjay.
And if you have already told the patient, then I don't think there's a big problem about it.
Well, what I'm wanting to say is that with all these VATS and everything, the management of intercostal drain is also, which we tend to miss out. I mean, even when we put a primary drain, how much of the tube is dripping into the water, that is the amount of water pressure against which the drainage is taking place. And once empyema you're draining, immediately in the next 4 or 5 hours, a lot of empyema drains out. And that is when the tubes get blocked and our drainage is unsuccessful. So we have to take care of the drainage and empty the drainage bottles maybe more frequently. Standard thing is once in 24 hours, but in these patients maybe every 4 hours, 5 hours, because if the water pressure is too much, it won't drain, it will block.
There are few points. One is the water column should be 2 to 3 centimeter. You can put it on low pressure suction. You should do regular milking. I have all that slides, but then I said, time we have whatever, 9:30 we have to hand over. But these are the routine things should be done to prevent the blockage. And the second part which we left in between, which I asked the Smith, is if you put intercostal drain, then how will you decide whether the patient is improving or not, and at what stage you will intervene? So let the Smith said primary they put intercostal drain, so let's hear from you.
No, it all depends on the presentation. If it's a primary ICD which has been inserted, that means there was no loculation found on ultrasound. The ICD has been inserted, then you wait for about 3 to 4 days. If there is clinical expansion, that means the air entry has come back, then there's really, you've won the battle partly at least. And if there is reduced air entry which is still continuing at the end of 48 hours, obviously that thing has got multiloculated and you need to do a VATS. So second criterion that we use is of fever. The minute your pus has drained, the fever has to come down. And if it's still not coming down, again that suggests that multilocculation has appeared. So again VATS is indicated.
So what our criteria is, you wait maybe 48 hours, repeat the X-ray, repeat the sonography maybe, and if you find significant collection is left behind, I think this is the time to go in. So if you believe in secondary VATS, do something like that. If you believe in primary VATS, do like what Ketan said. The end result both ways, if you do it, is fine. We will not go into that details right now, but what I was asking. Okay. In which patients or where one should prefer secondary VATS? Now, as far as India is concerned, it is a huge country and the VATS is not available everywhere. So, a lot of reasons. Endoscopic equipment may not be there, personnel may not be there. So there they can easily put the intercostal drain. And then at the end of 48 hours, if they think there is a thick peel, and if they still wish to get the VATS done, they have a time to refer the patient somewhere else. So for India, I think still the standard treatment will remain intercostal drain, and then it may be VATS or maybe open thoracotomy depending upon what you find. Because we can't, nobody would believe in primary thoracotomy. I don't know. Anybody does here primary thoracotomy? Not VATS, just patient of empyema comes and you do primary thoracotomy without insertion of intercostal drain. I don't think anybody, you do it? Okay. Okay. Okay.
You put in an intercostal drain, and after 7 days you go in for VATS or a open thoracotomy. The amount of bleeding and the morbidity is far more. So I decide on whether to intervene or to put an ICT on the character of the aspirate I get on first presentation. I do the LDH, I do the ADH, and I look at the pus, the leukocyte counts in the aspirate, and make up my mind, and also on the ultrasound, whether I should do primary VATS or an open thoracotomy or I put an ICT. ICT has made my life more difficult during subsequent surgery by bleeding and morbidity.
Okay, now the question would be, you said you will subject your patients to VATS also, or any particular way of differentiation, VATS versus thoracotomy, in which patient you will decide what?
Depending on the center I am working in.
Depending upon?
On the center I am working in.
Okay, okay, fine. Okay, now Meera.
One occasion, I think there are exceptions when you will have to do a primary thoracotomy. A child who had 6 months ago had an empyema, had chest tube, was sorted out, but for 6 months was lingering when he came to me with mild distress, needing antibiotics every 2-3 weeks, a CT showing multiple pockets and very minimal fluid with thickening of the pleura. Here is a child who's got symptoms but who's needing antibiotics, who's got thickened. I would go in for a primary.
Okay, so primary thoracotomy, we are speaking about chronic empyema, 110%. However, that is for the chronic empyema. And chronic empyema, I think everybody will do thoracotomy? Yes. Probably. Or those who are doing VATS, they may subject to VATS. If they are not possible, then do thoracotomy. Yes, Rajamani?
Yes, already we have discussed so many times regarding the empyema, so many forums. Still we are discussing, and future also we are going to discuss. At least one stage you must formulate guidelines, because most of the Western hospitals there is a fixed guidelines, particular disease. So regarding this, at least on stage, regarding the investigation, most of the remote centers, most of the investigation is not available. So regarding the investigation, one ultrasound abdomen, thorax and CT. When do you order ultrasound chest, or when do you order CT? And second thing, management regarding the antibiotics. When do you treat the patient antibiotic alone? If it is antibiotic, choice of the antibiotics. Regarding the prospect.
Jagdish?
Then second one, I will finish everything.
I will forget all your questions. You ask one by
Second thing, aspiration. When do you aspirate it, or when do you submit the patient to intercostal drainage? Once if you have put intercostal drainage, how do you follow this patient, and when do you submit the patient to primary VATS?
The last question we already answered.
Second thing, once we introduce ICD, how do you follow that? Then regarding the primary VATS, when do you directly submit the patient by primary VATS? Second thing,
okay, I understand. Rajamani, you want the protocol to be made. Okay, that Ravi and you handle for next PACI. We are not going to discuss that protocol today over here.
Because already we are discussing.
We have answered most of your questions, I think.
I just want to put one question in front of audience and everyone. This, how many of you have come across such type of empyema? Next slide. Next.
Everyone.
No, this thing I'm talking, just this video you go through, and I agree for early empymas, removal of this peel is not important, but in late, it results in scoliosis, severe chest cavity narrowing, and until unless you remove this peel, chest is not going to expand. How much you can...
Okay. Now,
I will conclude this. Finally, regarding the follow-up, some of the patient develops recurrent empyema in the same side, some of the patient develops opposite side, and some of the patient develops pyopericardium also. So that's the thing. Then how long you will continue the antibiotic for the empyema patient? So for everything you must have a guidelines.
Yeah, we will form the guidelines with your help. I will request Secretary Pacey to form the guidelines. Of course, I will be there. Don't worry about that.
One last comment.
Okay.
I think, in our center, we have thoracic surgeons who are extremely skilled. We do primary VATS. But the study that I mentioned, the Great Ormond Street study, essentially shows that you could actually get a good effective management by doing intercostal drainage. And that group actually, with urokinase, they did add urokinase, and with that they managed to treat children with loculations as well as without loculations. So I think the take-home message is, I think the ICD plus urokinase seems to be as good as VATS overall. But if you have surgeons who are experienced in doing VATS, that seems to be, a favorable option.
I think today we had quite a few discussion on fibrinolytics, but we don't have time to cover that. This topic is vast. We have covered only part of that, I am sure. There are hundreds of questions to be answered. However, there are few things. If you want to use fibrinolytics, use when you put intercostal drain along, at the same time, not to wait and then do it. That is what the literature says. However, still there is a lot of controversy. The theater is ready. So before we sum up, Satish is standing there for very long. So finish it in less than 30 seconds.
Just a very small comment.
Yeah.
While with this panel discussion, it's very clear that the management of early empyema is crystallized. The key thing is effective drainage. Whether you get by a pigtail with ultrasound guidance or by a primary VATS or by a good intercostal drainage under anesthesia or without, that's clear. But the late empyemas, everybody is considering only a CT and ultrasound picture suggestive of a collapsed lung and a thick peel as an indication for empyema or a primary thoracotomy. I beg to differ with that approach because most of our patients, over 120, maybe 200 cases, referred from all pediatric units in a big government setup, where even if I want to do a VATS in late empyemas, I don't get theater time, so they keep on waiting and they improve. So my criteria are, don't look at the CT, look at the clinical picture. If the child is toxic, running high-grade fever, very high counts, do something. Either VATS or primary decortication is your choice. But if the child is stable, not requiring oxygen, then forget about CT picture or ultrasound picture. They may look horrible, but all of them ultimately improve.
Okay.
It's a matter of